Welcome to The Ultimate Asset, the podcast where elite physicians, health strategists, and high-performing leaders explore what it really takes to protect and elevate your most valuable assets, your body and your mind. This is high-performance medicine, powered by Velocity Health. Hello, and welcome back to another episode of The Ultimate Asset. I am your host, Dr. Deep. I am a practicing precision medicine physician, the CEO and co-founder of Velocity Health. I am thrilled today to be joined by two of my amazing colleagues, Dr. Brittany Busse and Dr. Ashley Chambers. We are thrilled to have both of them. This is our focus this month on women's health. It is October. We wanted to spend some time really unpacking the state of women's health in this country, how we sort of see it from a precision medicine lens. And so we'll go deep on all sorts of things, from hormones to autoimmune conditions to whether or not we would recommend going into medicine to our daughters and our nieces. So why don't we start with some introductions? Dr. Brittany Busse is physician. She is the director of women's health here at Velocity Health. We've been working together for, almost 3 years at this point now, Brittany? So welcome. Can you tell us a little bit about your background?
Sure. So I actually got my medical degree from the University of Wisconsin. I started my career as a surgical resident, as some other famous physicians have done, and quickly realized that that's regimented, structured, don't ask questions, do what I say. That just mentality didn't work for me. Like, I wanted to help patients. I wanted to get in the trenches with them. I wanted to understand why they were making the decisions they were making, and then help them make the best possible decision they could for themselves and their own health. I also had some medical conditions of my own that were going on and found myself in a very hostile working environment. So it just made sense for me to separate from that program, spent a lot of time just looking at the various aspects of our medical system. Started telehealth in 2016, really early, when Uber drivers had no idea you could talk to a doctor via FaceTime. And that was actually a legitimate thing. And just really found my home here at Velocity, where I can bring that insatiable curiosity I have for what is new and interesting in medicine, and really take that into my own personal body laboratory, as well as expanding that into the laboratory of practice with my patients, who just love being on the cutting edge of keeping themselves active and healthy for the long term.
Well, thank you. And I appreciate that perspective and what you bring. I think so many of us here have learned and unlearned and retrained and trained in so many different aspects to get us to a point where we feel confident caring for folks. And one other quick comment is, we are all kind of biohackers, I think, at heart. A lot of us are trying many of the therapies and certainly trying to walk the walk as far as what our recommendations are for our patients as well. So thank you, Dr. Busse, for being here. We're excited to go deep with you. Dr. Chambers, hello. One of our newest members to our team. Welcome.
Thank you. Yeah, I'm Ashley. I'm an internal medicine physician. I have a little bit more of kind of a traditional straight through path. I, trained at Wright State for med school, Ohio State for residency, and then went directly into an employed outpatient internal medicine setting. And that was all fine and well for lots of years. I learned a lot of medicine. I learned how to practice in kind of a super busy outpatient setting, built a great patient panel of really kind people. But as I neared kind of that 10-year mark a couple years ago, I realized that practicing medicine in this manner just did not feel sustainable and did not feel right. I realized we were really good at being reactive, good at putting out fires, giving meds. Here, take this for diabetes, take this for blood pressure. But where was the real prevention? How are we really getting, behind all of these conditions? I wanted to catch the pre-diabetes before it was there, prevent the fatty liver. And I almost felt like we're doing people a disservice, by just being so reactive and treating things kind of down the line. So, that's where I've started to pivot over the past 2 years, and leaning more into lifestyle medicine, prevention, proactive care. And that's what landed me with Velocity Health. So I love being here, and I love having this opportunity to take the time and space and resources to really provide care for people, the way they need and deserve.
Yeah. And you mentioned a couple of things, as did Dr. Busse, that I think this is what we all sort of thought care would be like going into medical school, right? Where you could be highly relational with people. You have these intimate sort of conversations. You get let into the fabric of their lives and their, their culture. And you understand all these things because it all matters in your treatment plan, actually, right? That therapeutic relationship is so important. And, actually another thing I love about, you're joining us is that you bring, like I have had as well, a depth of experience in what traditional American primary care feels like and looks like right now, right? And I think every single one of us would say our healthcare experience is subpar, or that of our family members is subpar. And so when we set out to build Velocity Health, it was really with the goal to build the kind of clinic that we would want for ourselves and our families. And it is a physician-led organization. And so I'm so thrilled and thankful that both of you are here. The majority of patients that we take care of, actually more than 50% of our patients, are women. And it is important for us to understand, as Dr. Busse famously says, that women are not just men without penises, right? It is a very important point. Dr. Busse, could you double click on that comment? Because I think it is poignant, it's meant to raise eyebrows, but it is actually quite true as well.
Yeah. And I think, our medical system actually has known this for a long time, right? Because of the fact that they were like, we're going to exclude women from research because we think that their hormones mess up the results of our studies. And like, that's such a strange thought to me that like, we knew this whole time that women and men were dissimilar. So our answer to the problem was, let's just leave them out of research entirely. And maybe like what we find works for men will work sort of for them too. And that's, been the general way that research has progressed until about, the mid 90s, when people were like, well, maybe we should actually see how medicine affects women as well. And what we're learning more and more that although estrogen, progesterone are labeled sex hormones, because that was kind of the primary discovery that they were made in conjunction with, and they came from the ovaries, is that there are estrogen receptors in every tissue of our body. And we need estrogen for a variety of functions in our body. And so our physiology is very different from that of men. And it will change and cycle over the course of our lifetime, right? Because we start out with no periods, and then they suddenly happen, and then we get them cycling through every 30 days or so, depending on your health and your own personal cycle, and then they suddenly stop, right? And so all of your life, you're constantly in this ebb and flow of exposure in your bodies that's going to affect how everything else is carried out, from like your GI system to your brain health, to the health of your bones and muscles. It's just such a wild cycle that we go through as women. And
It's
one that's
interesting, right. You mentioned this really interesting fact about research, and I didn't actually know this until we were doing some research for this show as well. But in March of 1977, the FDA released a rule that excluded women of childbearing age from most studies because they were afraid of the impact that might have on the fetus. And well-meaning, intentioned principle, but then for 20 years nearly, we have this dearth of data, as you mentioned, in the research that doesn't allow us to actually extrapolate that well for all the reasons you just mentioned, because we are all very different beings physiologically. So interesting point there, and unfortunate. Do you feel that the research is now catching up, and now that we do have more representative samples, and we are understanding women's health from a research standpoint in a more robust way, or still a long way to go?
I think there's still a long way for us to go, honestly, in order to like quote unquote catch up. There is definitely still the fear in women of childbearing age, like you said, that they could be exposed to something that would affect the fetus, or their long-term fertility. There is a lot of, I would say, when something's already kind of been done and established. And for instance, let's take like statins for cholesterol. They're like, well, statins are great. They're safe. Someone should put them in the water. They're awesome. And no one ever studied, like, do they actually work in women? Is women's heart disease
Hmm.
the same as men's heart disease?
Interesting. Yeah.
And we're like finding out, no, it's not. And they have more side effects and the medicine doesn't work as well. But I think for so long, people were so entrenched in a medication that was first line, given to everybody, absolutely safe, that it's harder, I think, for them to step back and say, like, maybe we made a mistake and we should try to figure
Right.
out what the effects are, because everybody's kind of afraid, I think, to say you made a mistake. And I love that, T always says, like, we're scientists. Like, we should say, I made a mistake and restudy the effects of something. You should always be willing to change your mind as a scientist. And physicians are, above all, scientists.
Notoriously bad at that, I think, especially when guidelines and everything change. And you're right, that is the approach that we take. We're constantly learning with our patients. We're constantly learning with one another. We're pushing each other. We're finding new data. We're interviewing people on the cutting edge, and we're changing our mind on stuff, right? Importantly, because we want to bring the most important and up-to-date information to our patients. That is important. I don't know if you just saw this, Dr. Chambers, but Atia, as Dr. Busse said, just put out an article about coronary calcium screening and women's health as well, and how underrecognized cardiovascular disease can be in coronary calcium scoring as well for women in particular. What is your reaction to that? Do you see that in clinical practice? Are there other tests where we don't actually see the kinds of things? How do women present in different ways than men that we should be mindful of and understand?
Yeah, so definitely applicable in practice. Speaking from the traditional setting previously, right? I think, and kind of bouncing back to what Dr. Busse was saying too, in that it's so easy to be entrenched in like one way, especially in a traditional setting, right? Where there's no, like, docs aren't being fed even the most up-to-date information. So, we've just started using coronary calcium scores, I feel like, in traditional medicine more recently. So to have this kind of come along and Atia kind of pointing out that, hey, here's some data that shows that a score of 0, especially in a perimenopausal women, is not as reassuring as maybe we thought it was. So I think 100%, like, seeing this all the time. And so where I'm going with this is like, hey, look, some of these people, these women, if you're at higher risk due to family history or other factors, prediabetes, metabolically unhealthy, right? Something that would say, hey, like, this 0 doesn't sit right. Let's look further. Let's talk about a CCTA, some more intense
Right.
testing, invasive test, or intense, more in-depth testing.
Yeah, I mean, I think patients are often lulled into a sense of security as our clinicians by things like CACs. We talk about this all the time, right? A CAC of 0 gives us some directionality, but it's all in context, right? How old is that person? Like, anyone in their 30s more than likely going to have a CAC of 0, right? Unless they're very advanced disease. And what folks don't understand is that, CAC calcifications are a later stage finding of calcified plaque, right? And what we actually care about are these unstable, soft coronary plaques. And those don't show up and don't present. And often we miss those, and that's the thing that leads to the silent heart attack or stroke. And so, that's where I think a CCTA is a great example, like you said, of where we need to understand the limitations of our diagnostics and bump that up next to the risk profile of patients, and understand who they are as people and choose the right diagnostics for them.
Yeah. And what I would add to that is that, going back to what I talked about with estrogen, is that, heart tissue also has estrogen receptors, and our cholesterol levels are actually also dependent on estrogen. So women's cholesterol levels also fluctuate with their cycle. And when we start to hit perimenopause and menopause, that's oftentimes a first sign of perimenopause, is a jump in ApoB. So if you're looking at a CAC in a woman who's probably not going to go on to even develop those types of advanced plaques until later on in life, right? It was one of the whole problems with the WHI trial, looking at, does estrogen treatment affect coronary vascular disease, was they were getting these women way too late. Like, coronary vascular disease had already built up at that point between the age of menopause and 65 when they were enrolled in the study. The other thing is that women we hear that, again, these medical terms or sayings that we always hear, right? It's like, oh, what's the first sign of a heart disease? A fatal heart attack in men, right? And the first sign of heart disease in women is often microvascular disease. It's things that doctors brush under the table. It's fatigue, it's shortness of breath, it's weakness, it's nausea, kind of this generalized malaise of the heart that's due to these tiny microvascular complications. They're not going to as often be, subject of the widowmaker, right? Like that massive
Right.
plaque rupture
Right.
that's going to come from one of those unstable plaques. So again, like, is the testing going
Just to corroborate that, we found other data that showed a recent survey of 900 women showed that 94.4% of them and 88% of women in the younger category felt ignored or dismissed when seeking medical help. Right? Like, we're not saying 50% of patients, we're saying 80 and 90%. Even if you think we're off by 10 or 15% on those surveys and whatever, like, that is not right. We are obviously missing something. And I think, to your point, there are different presentations that I think we're just not trained to see. And there's all sorts of data to suggest that clinicians, men especially, dismiss symptoms, often misdiagnose histrionics, depression, anxiety, and miss real pathology that's happening. Not to say that's other stuff's not real pathology, but miss organic pathology that we should have intervened upon. Do you all see this in practice still currently? Like, the women that you take care of that come to you, are many of them disenfranchised with the medical establishment? And do they all have a story like this of being dismissed or told their symptoms are nothing to worry about?
Yeah, I
Ashley,
mean,
what do
I
you
think
think?
100%. I, I think I've heard the number. The average amount of time you get actually with your physician now is 7 minutes. And I mean, I think that's like on a good day. You get interrupted within the first like minute, 30 seconds.
Yep.
And it's true. And I think, yes, patients feel unheard, especially women. They feel cut off. They feel like pigeonholed, all of those things. So I hear this all the time. And I think I will maintain, I think it comes back to time. I think you need, as docs, you need time with your patients. You need time to listen. You need time to feel unhurried and to hear what they're trying to tell you, because I think that old adage that we all learned in med school is true. I mean, you can get so many answers from just the history alone and from listening and not interrupting and hearing the whole story. So yes, 100% is a short answer.
Well, that's why we spend 60 to 90 minutes with our patients. It takes time, right, to actually know someone, and those stats are sad and unfortunate. I want to pivot a little bit. I think one of the things we care for a lot in our practice are along the HPA axis, our hormones. And you both are what I consider experts in women's hormonal management and therapy, perimenopausal care. So why don't we talk through a few things here? We have patients that are on the younger end. We have teens and 20s all the way up into their 60s and 70s. So we'll spend a little bit of time on the edges, but the bulk on that middle group there. So let's start with you, Dr. Busse. You've taken care of some of our younger patients as young women are coming in and asking about birth control. What is your general conversation you have with women about birth control? Do you think that there's a right place for it, a wrong place for it? How do you use those in your practice? Oral contraceptives.
I think, with any type of like hormonal intervention, you have to think, like we're talking about, you have to know the person that you're talking to, like what are their short and their long-term goals. And then honestly, like asking them, what is their experience with this? Like, what do they know about it? What is their direction that they want to go in? I'm not against, birth control. Obviously, like there's a lot of good reasons why women don't want to be pregnant young. For me, I was in medical school, college, early in my career, like having a pregnancy anytime during that period would have significantly derailed my career plans to a point. And I also wasn't ready to be a parent. And so having that choice made available to you is really important. Do we always have the best options? maybe not. I think, my personal choice was an IUD. I found that to be better than, the hormonal pill. I also do work with women in perimenopause, where the Menopause Society does still say that in your 40s, birth control doses are more appropriate for women for symptom control because of the hormonal chaos that is associated with the perimenopause period. Some women can get away with lower dose, but most do require that higher level of synthetic hormone. So, I tend to use things like the birth control patch so that you don't have the associated inflammation and the blood clotting risks and everything else that come along with the oral option. So I think having a discussion with women, finding out what works for them, is really important when it comes to any kind of oral hormones or topical or anything that's going to affect them long term, because there are always side effects.
Yeah, absolutely there are. And that's a very thoughtful approach. Thank you for walking us through that. I think another thing that younger women come to us sometimes for advice and guidance around is just family planning and fertility and getting ready because they want to have a pregnancy. So Dr. Chambers, in those circumstances, what's some of your baseline guidance for young women who are approaching a phase where they are wanting to optimize themselves in preparation for an upcoming pregnancy?
Yeah, I think it's about taking kind of a whole look at especially your in all facets of health, but a lot about your metabolic health and kind of going deep into some of like the lab evaluation, your glucose, your lipids, just making sure kind of metabolically things are aligned going into pregnancy. And then I think having kind of a good conversation about maybe if you were on some sort of birth control pill, what coming off that might look like, or pulling your IUD out, cycle tracking and things like that. So I just think, again, kind of like Dr. Busse said, just meeting them where they're at and kind of talking through like, hey, this is what happened in the past for you, and kind of laying out expectations. And also like making sure they understand like this is what the year of trying to conceive could look like. And, it's not the same for everybody. And I think a lot of us kind of go into that blind a little bit, just assuming it's going to like happen magically and easily. And that's not the case for everybody. So I think laying out some of those expectations too beforehand is helpful.
Yeah, I think that's one of those like general misconceptions, right? I know when I was young and I was on the pill, like if I miss a day, like if I'm off by like an hour, I'm going to magically become pregnant. Like you're so fearful about this. So you think that like, oh, the minute I stop my birth control pills, I'm just going to get pregnant. And I would say the majority of women, that is not the case. And if it's, due to the impact of the birth control or the fact that they're older or less metabolically healthy, as Dr. Chambers said, like it's oftentimes hard to tell and to discern that in just like a quick office visit, like we're talking about. Like you really have to dig into what's happening with women. I know, myself, when I came off of all of the hormones, the pill, got the IUD out, I still had a lot of side effects like acne, like weight fluctuations. My hormones were really like out of control. And um, finding, like a diet that worked for my health, a way to metabolize any extra estrogen that was circulating in my system, right? Because when your body tries to get rid of hormones, it's going to put them into your liver and into your bile, and then it's going to go into your intestines. If you're not eating enough fiber, that hormone is going to go right back into your bloodstream, and it's just going to keep
Interesting.
circulating over and over and over again. You're going to keep dealing with the effects of excess estrogen in your body. So knowing, a lot about how those things are interrelated became really important for me, and changing my diet and eating in such a way that I was being, and putting myself into a state that would be supportive for my fertility, and like suddenly, yes, magically getting pregnant, like, oh, wow, I was doing this for like 5
Well,
months.
maybe this is a good place to ask about the famous Dr. Busse bean diet. Do you want to tell the audience about that?
It's not mine. I cannot take
Mhm.
ownership of the bean diet. I actually learned about it from a woman on Instagram. We can get into more social media stuff later, but her name's Unique Hammond. She is a coach, and then she had gotten it from this woman, Karen Hurd, who actually used it to help her daughter eliminate some toxins that had gotten into her body from, like, I forget, it was some house cleaning or something like that, where she had been basically poisoned. And they found that because of what I was talking about, the enterohepatic circulation in our bodies, is that is how our body deals with all kinds of toxins and also excess hormones, or even just normal amounts of hormones that we have in our bodies, is to try to excrete them into our digestive system. So most of our diets are completely deficient in fiber. I know, like, I have two things I always have my women tracking, and that is their protein intake and their fiber intake, especially soluble fiber like legumes, because that is the vehicle that your bile actually binds to so that it can be eliminated in your stool. So without soluble fiber, again, like legumes, some people like psyllium husk. I know some of my patients hate it. If they're listening, they're going to laugh. Because it doesn't taste great, but it's very effective, like medicinally in this circumstance, because it will bind to that. It will take out the cholesterol, it'll take out the hormones, it'll take out the toxins, and it'll move it all into the toilet to be disposed of the way you wanted it to, right? And so, when I think about using beans, like I've had patients take them. And I'm like, it's medicine. I don't care if you don't like them. Like, you'll make a big pot of them. You're going to keep a jar of them in your fridge and you're going to eat them 4 or 5 times a day. And like, I've had women just like have so many like amazing changes in their health, not just from like a hormonal and
That's
fertility
interesting. Yeah.
standpoint, but yeah, skin care, their skin gets better, their GI health is better, everything.
And so, like, what's the actual recipe? How many beans? Like, what would you guide someone to eat?
So
What are you doing?
I have people start low, right? Like, because some people are not going to tolerate them and they'll get gas and they'll be
Yeah.
like, I'm not eating these. So, typically depending on the person, if you have your gallbladder still, you can do it just with meals, because that's when the bile is going to be excreted from your gallbladder. So usually I have people even just start out with like a tablespoon at mealtime, moving up to like a quarter to a third of a cup with each meal. So you just kind of incorporate that into the recipes. You want to
Not
avoid
much, right? That's not
oil.
that hard. Most folks can
Yeah.
just, scarf that down. But look, I think it highlights 2 points. One is we're often trying to pair both our lifestyle interventions, which are our diet and exercise, sleep, these things, as well as using traditional medications. I think what I love about our practice is how seamlessly we mold and meld both of those things together. And sometimes it's because the evidence suggests we should do both, right? And sometimes it's because we're meeting people where they are. Someone's like, I don't want to go on an OCP or whatever, right? Or I don't want to go on bioidentical hormones. Like, what other options do I have? And it's nice to have folks like you all who actually understand this data and have other, more natural ways for us to handle some of these circumstances. So let's fast forward a little bit in life and talk about an archetype that I think we see very often. Middle-aged woman, somewhere in the range 45 to 55, comes to us with some brain fog, decreased energy, hot flashes. Where do you sort of go from there? Like, what is your line of questioning? What other information do you need to understand? And how do you sort of triangulate on, this is a hormonal issue that I could potentially change by, the right combination of interventions together? So Dr. Chambers, you want to take that first, and then maybe Dr. Busse after?
Yeah, I think, I like to know everything. So I will talk about all body systems, kind of head to toe. But I think, focusing on menstrual cycles, what that used to be like, how that's changed. Are they heavy, irregular, both, all over the place? Are there hot flashes all the time? How's your mood? How's your skin, your hair, your bowels, right? Everything. But I think it's a matter of kind of looking at, yes, the age plays a role, right? We think, average age of menopause, 51, 52, going back kind of 10 years behind earlier than that, so 2 to 10 years, perimenopause can kind of fall anywhere in there. And that's where I think there's also a lot of
10
misconceptions.
years ahead of actual menopause, women can start to feel some of these symptoms leading up.
Yeah, 100%. And I think that's where some of the knowledge gap lies too in healthcare now, is that a lot of women, say your early 40s, you go to your doctor and you're like, wow, I'm feeling terrible. I have kind of this variety of symptoms, brain fog, muscle pain, joint aches. And you kind of get told like, oh, like you have a job, you have kids, you're tired, like exercise and, take care of yourself, and like brushed off. And I think we're all left kind of flailing about and really like, no, this isn't my body. This isn't me. I don't feel like myself. And I think kind of going back to like really listening to your patients and hearing that like, this isn't how they've felt in the past and something must be going on. So I think it's kind of taking that whole clinical picture, the timeline, menstrual cycles, age, and kind of saying, hey, no, maybe this is more of like a perimenopause type picture and your estrogen is
Right.
really low and then it's really high and really low and really high and you feel terrible, like kind of all throughout. And that's where we talk about some lab work and, the utility of that and how to interpret that alongside,
Right.
more of the whole clinical picture.
I think one thing to just highlight there is getting the data, right? Like most PCPs, we don't have the time or knowledge or, expertise or, information to even interpret all these labs. I think we've all spent a lot of time, looking and studying things like Dutch tests and looking at hormone profiles and understanding the variation that happens throughout time, diurnally and throughout cycles. And there's a lot of nuance there, right? And I think sometimes we see patients come to us with these head scratcher regimens that we're not sure how they sort of got on, right? And I think to your point, it takes that extremely in-depth approach. Dr. Busse, anything to add to that on how you evaluate women coming to you with that sort of set of symptoms?
So I'd say like the number one symptom of perimenopause that a woman will present to you with will be like, I don't feel like myself. Like when a woman walks in your office and says, I don't feel like myself, and she's like in her late 30s to like mid 40s, that's the first sign you should be looking for perimenopause. There, like
Interesting.
we talked about in the beginning, there's estrogen receptors in every tissue of your body. So there's actually probably between 30 and 50 symptoms of menopause. We actually have a survey that we give to all of our female patients that kind of look at those things, because there are things like Ashley was saying, like joint pain, for instance. Like all my patients come in, oh, my joints hurt, and I'm like, all right, have you been checked for perimenopause? So it's not just the typical things that we came to like characterize as menopause, like the hot flashes or the brain fog. Like it's just really that sensation, like I don't feel like myself, I don't look like myself. Like there's estrogen receptors in your skin. Your skin's going to start wrinkling and sagging more. Your hair might start thinning and falling out. Like all of these things, again, mental health is often associated with the depletion of estrogen. So depression and anxiety goes through the roof. Irritability, right? The crazy menopause lady. But it's because like we feel so disconnected from ourselves and again, these cycles that we've lived with for so much of our lives. Yeah, it's really disconcerting to suddenly have your brain be deprived of estrogen. Lisa Mosconi talks about that all the time, that the brain is full of estrogen receptors and your brain is going to start withdrawing from estrogen. And during that time, it's going to need to remodel itself to this new archetype, right? Just like during pregnancy, our brain gets flooded with estrogen and progesterone and we get pregnancy brain, which kind of sounds a lot like menopause, but for the opposite reason, right? Brain fog, all these things. But I don't know any woman who wouldn't tell you that after her baby was born, she could smell her baby's poop from like a mile away, and she knows that was her baby, right? And it's just these things that happen to our brain, like they have positive eventual outcomes for most of us, aside from the association with dementia and Alzheimer's. But we have to go through this, and you're just going to end up feeling really disoriented. And so knowing that when a woman comes to you and starts telling you these things, like you can't just brush it off. And like Ashley said, like, oh, you're stressed, all these things, because it could be heart palpitations, like mitral valve prolapse. Women were told that was another like kind of symptom of just being a little bit crazy or histrionic. So a doctor, cardiologist said, if I see mitral valve prolapse in someone's chart, I know a cardiologist wrote her off.
Wow.
And that's one of those things that's just so dangerous to do, especially again for women in perimenopause, because as we were talking about, your cholesterol is going to go up insulin resistance is going to go up. You're at higher risk for heart disease. You're at higher risk for, the onset of the changes that will ultimately lead to dementia. Your bone mass is going to go down. Your muscle mass is going to go down. Like, all of these things are going to set you up for frailty, and for a shorter lifespan. If we don't identify this right away and come up with a plan, whether that is, hormone therapy or something else. Like, we need to know where we stand in the beginning. Like Ash was saying, prevention is the key to this. Like, we can't prevent menopause. Menopause is going to happen no matter what, but
Right.
we can prevent the negative effects of estrogen withdrawal.
Well, I don't think I've ever heard a better explanation than that on sort of how estrogen is impacting during different phases of life. I think once you've both sort of convinced yourselves that a patient that you're chatting with and the symptoms that they're presenting with are related to perimenopause and this estrogen depletion, what's sort of your next step? Like, when do you decide to start hormone replacement therapy? And maybe in that, Dr. Busse, you could start with this. Could you talk to us in the audience a little bit about the Women's Health Initiative and sort of the negative things we took from that, and maybe in the wrong sort of light, and what that's done to sort of the conversation around beginning HRT, especially for women?
Yeah. So as I mentioned earlier, that, the sad part about the Women's Health Initiative was they started it in women of advanced age who had been outside of menopause for 10 or more years at that point, who had never received any hormone therapy. That was one of the conditions of being enrolled in the study, was that you could never have received any kind of hormone therapy up until that point. And the reason why they did this, again, looking from a research standpoint, it makes sense. They were looking for an endpoint of cardiovascular disease mortality. And if the patients were any younger, they probably wouldn't have died of heart attacks. And so in order to power the study to find an effect, they had to choose older women for the study. When they did that, they were dealing with women who not only hadn't been exposed to estrogen for a very long period of time, but those who had now diminished estrogen receptors, because their body had already gone through, a prolonged period of time with no estrogen. So we downregulated all the receptors, or we, as in the women in the study, and they probably wouldn't have seen much benefit from the estrogen that was administered to them. In addition, you had a very high percentage of women in this group who were smokers and who were obese. Probably another reason why they didn't receive hormone therapy in the first place, because
Right.
for the most part, doctors won't give hormones to women who smoke because the risk for blood clots. And so a large majority of these women were smokers. And what the results of the study showed was that the patients who were treated with estrogen and a progestin called medroxyprogesterone, or MPA, had more breast cancer, they had more heart attacks, and they had strokes, and they actually developed more dementia. So they pulled the study, said estrogen is toxic, nobody should get it, and we're putting a black box warning on it that says you should never get this. So now doctors who are more than happy to give women of childbearing age birth control pills and synthetic estrogen and progesterone will take that away from you so fast the minute they think that you are menopausal, and won't give you anything back in return. Because, like, now estrogen after menopause is dangerous. Before menopause, it was okay. And it makes absolutely no sense, right? Like, that we would do something like that, like give people a ton of hormones and then suddenly take them away based on the results of one study that was, for all intents and purposes, extremely faulty in its design. If you're looking for how does estrogen benefit women who are perimenopausal through the menopause transition, and then from that point on, because if you keep receiving estrogen, you're going to have estrogen receptors. We see in women that we treat here that will lower their cholesterol, lower their ApoB, will preserve a lot of their insulin sensitivity, right? Like, there's other things oftentimes we need to do, but for some women, it is as simple as that. Like, they are doing everything right? Like they're still exercising, they are still eating healthy, and suddenly they're gaining weight and they don't understand why. Well, a lot of that is just the insulin resistance that accompanies perimenopause. So when you give women back estrogen at the dose that they needed at the level that's physiologically appropriate for them, you keep those estrogen receptors at the physiological level as well throughout their entire body, and you're going to most likely prevent a lot of those consequences. Now, do we have the research to back it up? No, because nobody's doing a study with 40-year-olds extending on until their 70s to see what happens to them, right? And now we've had this huge window of missed opportunity where we could have been looking for that. But when I see that in my patients, I see the results that speak for themselves, right? Like better cholesterol, better heart health, better insulin sensitivity. And I know that I'm setting those women up for long-term health, which is what a lot of them want. Like so many of us are having children now later. We're going straight from childbearing to perimenopause. And we have children who are, young, right? Less than 10 years old. And we're in our mid 40s to 50s. I'm like, well, I want to see my children grow up. I don't want to have a heart attack when I'm 60, So that's really important.
But what should the punchline be for clinicians and patients then on estrogen replacement? Let's start with that. Like, does giving estrogen in perimenopause and beyond increase like myocardial adverse events?
No.
Yes or
I
no?
would say that it decreases them.
Okay. Does it increase risk of breast or ovarian cancer?
Unlikely.
Does it increase risk of dementia?
Also unlikely, although there was a study, but again, it was started in women much later, that did show increased risk of dementia. Again, they were looking at the combined, usually like Premarin. It wasn't bioidentical hormones, it was synthetic hormones that did show a relationship for the estrogen progesterone group, not for estrogen only.
And I think, Brittany, that point about the formula used is so important now. The WHI, I mean, a lot of that was it was conjugated equine estrogen. So, you weren't comparing like apples to apples. It's not the same. Now we can use the transdermal patch. We're using bioidentical options.
So, Dr. Chambers, tell us a bit about that. Like, what do you mean by bioidentical? Why is that better than synthetic? And then what's sort of like your go-to? What do you reach for when you're thinking about HRT in women of perimenopausal age?
Bioidentical means the hormone basically is identical to what the body produces. So like estradiol and progesterone. And they can be FDA approved products, right? So estradiol patches, so your transdermal estrogen, micronized progesterone. But they're also compounded products or things that are not FDA approved. So you just have to be kind of careful, I think, as a patient or consumer, paying attention to what you're using or what your provider may be giving you. More of like the conventional hormones, more of like the older traditional versions of hormone therapy, conjugated equine estrogen. So Premarin comes from horse urine. So made to act like these in our body, but not acting exactly like these in our body. And that's where the WHI study used more of these conventional hormones. So you really can't apply, those same things to now using a transdermal patch. I tend to like the transdermal estrogen patch and then the micronized progesterone as my first option with a patient. And then kind of back to like the birth control discussion, though, I think it's very nuanced. And, maybe she doesn't like where the patch is or the adhesive, or then you're using like a gel, or, there's lots of different formulations. And so I think explaining risks, benefits to your patient and kind of coming up with that plan together and tinkering, right? You try something, you put it on, you try for a month, you get labs, you give some feedback, how's it working for you? And maybe you try something else and you kind of play with it and adjust.
There are other synthetics, right? So there's ethinyl estradiol. Again, that's kind of like the main synthetic estradiol that's in birth control pills. It's, hundreds of times more potent than estradiol is in our bodies, so you can get away with a lower dose. There's also synthetic progestins, like norgestimate, which can have actually like androgenic effects. So it's curious to me. I have seen patients come in on synthetics like ethanol, estradiol, and norgestimate. And to me, again, they're postmenopausal. So I'm a little bit curious, why the doctors feel more comfortable with those medications. Again, they're very similar to a birth control pill. So I think that
Right.
might be some of the reason why people end up staying on a compound like that. Whereas again, you're looking at the recommendations from the Menopause Society, and, for the most part right now, they feel that, women who are below the age of menopause, like 51, 52, birth control is typically the standard option. Again, the synthetics, because, they are formulated in such a way that will remove a lot of that chaos. If we want to go back and talk about like lab testing and stuff like that in perimenopause, we can. So you're trying to remove those like peaks and troughs, but you won't be able to do that necessarily on like a hormone therapy replacement dose because it is so much smaller. And so they do recommend that, and then potentially transitioning to menopause replacement dose after the usual age of menopause, which they would say like at least like 52. So that is their current recommendations.
So
Who knows, if they'll want to change that later on to something like of more of a bioidentical, because other countries do have birth control pills and other things that are identical, like estradiol and progesterone based. And it just so
interesting.
happens that here in our country, they're mostly synthetic based.
Yeah, I'm not sure why that is, but it is both your practice to start with bioidentical estrogen and progesterone. It sounds like. When do you all layer on testosterone? Is there a role for testosterone in hormone optimization therapy for women?
I think it depends. Again, like I would never do that first line for a woman because I typically want to see like where things shake out with, like, first of all, the estrogen. If they don't have a uterus, they may not need progesterone. And so we want to see what side effects they're having, what other menopause symptoms they might still be having, because things like insomnia respond better to progesterone. And so even for a woman without a uterus, sometimes progesterone is warranted. And then for testosterone, the main indication right now would be hypoactive sexual desire, or low libido. So I was once interested in sex, now I'm not, and it's distressing to that person. And in that case, you're looking to replace them to a physiologic level, not a male level of testosterone. But
What's a
unfortunately,
physiologic level that you're
you're gonna
trying
look at
to
like
test?
maybe like 50 to 70 or so for a woman, whereas
Mhm.
men you're looking to shoot into like the hundreds. I've definitely had female patients whose providers were not judiciously using testosterone, because the thing is that, like, we know this from anecdotal evidence of like men using steroids and anabolics, is it makes them feel really good. Right. So if you get a woman on a pretty high dose of testosterone, she may initially feel great, like have a lot of energy suddenly, like loves like working out because it will help build muscle potentially, and like all of these other things. Um, and they may be attracted to some of those side effects. What they won't be attracted to is deepening of the voice, potential hair loss, acne, and other effects of
Yeah.
overdosing on testosterone. So a lot of women will come to you and also just say, like, it makes me feel crazy. So you want to be
Yeah.
pretty judicious, like using a very tiny amount of one of the male approved dosing. Typically I would go with like androgel. It's easy. You use just kind of like
Use
a
a
really
gel.
tiny
Yeah.
piece of the gel. I know there are providers out there who do have women inject subcutaneously, and find that a very, very tiny dose of that works as well. But it's hard. It's hard because you're using such a small dose. It's like hard
Right.
to
Right.
draw it up. So I think that from my experience, like the gel works the best. And again, with the right woman who feels like she's gotten a lot out of it, but her testosterone level is still low and she's having symptoms. We don't know enough about whether or not it does help with bone loss and muscle growth in women, and sarcopenia and frailty prevention, to say that like every woman should be on testosterone.
Right.
And I think this is where, women need to be careful about where they're getting it, who they're getting it from. um, social media is such a hotbed of information, especially with regards to women's health these days, for better or worse. And I think there's a lot of companies and providers kind of pushing this on women, and women are, hey, I'm just going to start testosterone without trying all these other things. And they're getting pellets and, by folks who aren't even really like, trained to
Really
give.
qualified.
Yeah. And I have a doctor friend who does aesthetics, and she does laser, and she is doing laser on women who have extra hair growth from their pellets. So they're getting their pellets, and then they're having hair growth, and they're going to get their laser. And she's like, it's the Wild West out there. And it is. So I think, both physicians and patients need to be aware. And I think that's why at Velocity, we come from, an evidence-based place, and we're listening to our patients and kind of coming up with a stepwise plan.
And I guess just like to talk about the pellets, I think it is important that we do just stop a moment on those. I think a lot of menopause specialists are letting people know this, but I want to make sure it's out there, even from our mouths too, is that these pellets were developed for men. There is not a female pellet formulation. Women are being given the lowest dose men's pellet. None of these companies have any data about how these things dissolve over time, what the blood levels are, what the side effects are, because these are not legitimate pharmaceuticals, right? Like, they are being pushed by specific companies. And so women can expect to have a testosterone level on this pellet minimum 200 to 300. Minimum.
Wow.
And potentially in the thousands. And when that pellet dissolves over the course of like months, if they got enough of a jolt from it, they're kind of going to be addicted to it, honestly. And they're going to keep coming back. So if you're going to an office and you're talking about your hormones, or you're going to a hormone specialist, that is kind of a red flag. And if they say, yeah, we put pellets in everybody, then run. Please run screaming from the office, because like, you shouldn't ever do anything to everybody. Like, and if you're not thinking about what these things are, and mind you, I know some women who love pellets. Like, it's fine. If you love it, do it. I will never, ever prescribe them ever because of these facts, until we understand like how they affect women. If there's a women's formulation, something that keeps you well below 100, and you don't have to deal with these side effects. You're not running to the aesthetics practice getting, your beard lasered off, right? Like, that's just unacceptable. Because that's going to be a permanent problem.
We've all seen patients who have unfortunately been victim to the misinformation and the practitioners who potentially don't have the same kind of evidence-based approach as we do. So last question on this is what is that approach to monitoring? Like, what is the appropriate time frame to understand tested change? When should you start a woman on hormone optimization therapy? When are you looking at labs next? What are you sort of, because a lot of these folks come to us and say, oh yeah, I got put on this stuff a year ago or 6 months ago, and I've never talked to anyone after that. And I think we probably think that's not great care, but would love to hear how you all articulate that.
Yeah.
Yeah, I would love labs, a month in if I can, at least at 3 months. But, I like the data points, and I like to see how that correlates with how they're feeling. So 1 month, 3 months, and then we can kind of space it out. Maybe it's 3 months, 6 months, kind of as if they're stable or we've made a change and how they're doing. So it can adjust, I think, clinically based on the situation, but I think the more data, the better, honestly.
Yeah. And I think, as I mentioned previously, like, so baseline lab testing is really plus or minus in perimenopause. I think Menopause Society says no. A lot of doctors still test it, and we can. I don't know that you learn a lot, right? Because depending on where you are in like that spike/trough cycle, you may have a very high estrogen level or normal estrogen level or a low estrogen level. We're really going to be treating based on symptoms during perimenopause, but then post-menopause, I would say we're, definitely checking, like Ashley said. I think 6 weeks is usually about where I would check somebody, even if they're not, technically due for their lab. So you want to know what their level is. So you have your baseline level, then you have your 6-week testing. You can make adjustments from there. And like Ashley said, after that, once somebody's stabilized over the course of like 3 to 6 months, you really don't have to check that often, unless again they start having symptoms. If they start having symptoms, you're going to want to understand what's happening with their hormones. So
most women on the same like once you get to that 6 month spot, are they on the same regimen for like years at a time, or is it
Yeah,
you have to
typically. I
adjust
mean,
every few
especially
months?
post-menopause. Post-menopause, they could just be on the same regimen indefinitely. I think there's not a lot of people who are in the camp of like, we need to stop now at a certain
I
time. I
was
think,
going to ask, are there like real indications outside of like you're having a side effect or anything, like just from an age or time exposure standpoint, when you should start tapering people off?
yeah, I think right now, if someone's feeling good and they haven't, developed heart disease or dementia or breast cancer, there's really no reason to take women's hormones away from them at a certain point. Because then again, what are you doing? Like, oh, now the age of menopause is 65. Like, we'll stretch you out from 55 to 65, and then we'll take your hormones away and basically slam you into all the symptoms and all the negative effects of menopause. But we just delayed it 10 years. So now instead of getting heart disease and dementia at age 70, you're going to get it at age 80. Well, I mean, I was hoping to live disease free well to 100. Like, I'm not about to like have somebody take away my hormones for like the last 35 years of my life and potentially cause me
Right.
to succumb to illness sooner. So that's something that aside from like a real like contraindication, like they did develop breast cancer, now they need to come off of it because they have a hormone responsive tumor, or something else, like maybe they did get a blood clot because they were on an oral formulation, and then it's a discussion, right? Like, we got to talk to the patients, we got to find out like what is their risk tolerance, how do they feel about this, what do they want to do next. I don't believe in like these absolute time frames, these absolute contraindications, because every single person is different, right? And every single person is going to have a different vision for how they want to continue living the rest of their life. And so I want to make sure that I'm taking that into account at every visit. It's why I want to develop this long-term relationship with patients. I think some patients come in, think like, oh, I'm going to see this doctor once or for a couple months or for a year, and they're gonna fix me up nice, and I'm just gonna go to somebody else and like let them handle it after that. And maybe that works out for you, but there's always something, right, that you need that extra relationship with your doctor for, because your life may seem stable right now,
Mhm.
and then what are you gonna do if it does suddenly change? So,
Well, we
I'm trying
all love those
to,
longitudinal relationships. I think having history with a patient allows you to make better decisions together and understand the context of their lives. We had a lot of other very specific questions from our audience and patients about things like GI health and adrenal fatigue and autoimmune conditions. I think we'll save those for a separate episode. What I'd like to just chat about as we round out here are a couple of things. One is just zooming out, talking a little bit more about the wellness industry. We're kind of all part of this now, and I think we see a lot of different trends here that I'd like to unpack briefly, and then where you all sort of see medicine, health going, especially for women in the future. And so, on that first topic, do you all believe the general trend and that the wellness industry is generally empowering women or manipulating women in a negative way? What's your stance on that?
I mean, it feels like a bit of both, honestly. I think I love hearing women's voices, and I feel like there's been a push to listen, right? Especially in perimenopause, and menopause health is having such a moment out there. So I think that is very empowering. But then I think it can so easily flip to a manipulation piece, especially women are being vulnerable. They're sharing, they're out there looking for answers, and companies can just kind of swoop in and capitalize on that and use more of like a fear marketing strategy, shame, anti-aging, kind of all of that stuff. And then, women can kind of fall into that. So I see it as a kind of a bit of push and pull, a little bit of both.
Mhm. Yeah, I think that the problem is oversimplification and also like generalization. And then yeah, kind of playing off of like the fears of women. Um, I see a lot of like, especially around like exercise, right? Of telling women to stop doing cardio at 40. It's like, oh no, cardio will now make you fat. I'm like, really? Like, we're gonna go there? Like, at what point do women have to stop worrying about quote unquote being fat, first of all? And then second of all, like, to tell people that a whole realm of exercise is suddenly off limits to you unless you're just marching around your, neighborhood in a weighted vest. And
Right.
like, I know lots of women who run marathons after 40 all the way into like their 60s, and their body does well with that and they tolerate it well. And they enjoy it. It's awesome for them. And some women love swimming. Some people love rowing, dancing. All that stuff's cardio, right? Like, cardiovascular health is super important. So I think when we start like oversimplifying something and then like that message just gets propagated like over and over and over because one person said it and got like 1 million views. And so now every
Right.
other person is like, I want to say the same thing as that person. So we're really struggling in this time of like, this viralization of something that could be like a very harmful idea, um, just through the the rapidity with which these things propagate themselves on these
Right.
algorithms.
Right.
So women need to understand that like there is no one size fits all here. Like, yes, do find a doctor. I love that people are saying like find a doctor who understands this and who listens to you. Go to the Menopause Society. Find somebody on a podcast or something else where they said something that you relate to and work with that person or somebody like them, and find somebody who will listen to you. I think that's a very helpful message. And at the same time, I do want to make sure, as Ashley said and how we talked about in the beginning, like working in that realm of medicine, like that corporatized medicine that we all have worked in, we don't want to demonize the doctors either, right? Like, there's a tendency for people to say like, my doctor doesn't listen to me. My doctor won't order X test. And they have to understand that that's like saying the waitress burned my steak, right? Just because you see the doctor doesn't
Yep.
mean that that is ultimately always our decision. Like Ashley said, we get 7 minutes on a good day to talk to you. We have
I mean,
paperwork
it's
that
an
has
amazing point
to
is
be
that
done.
the system is stacked against all of us, right? Like,
Yep.
again, going back to the initial point, none of us think healthcare is working for any of us, certainly not the women in our lives. And a lot of that is because we're all clinicians, widgets in the machine as well, right? We're dictated by RVUs and volume and production more than you'd ever know. That 7 minutes is because there's 20 other people waiting in the waiting room and I've got to meet these quality metrics, that 30-second interruptions, because I need to hit these things. Otherwise, the man's going to get on me, right? And so I think there's a whole other topic and conversation around breaking free from the reins of corporate medicine and empowering independent practices and clinicians like ours to do the right thing, which is spend time with people and actually understand who they are and have these very nuanced, complex conversations that take time.
I think where I was going
It,
with that too is just, the answer is not then to jump on a telehealth platform specific for perimenopause, right?
yeah,
Like, because it's the same corporate model. Like, that doctor's still being given, 15 to 30 minutes to see you to just
right.
deal with your perimenopause because that's what the platform is there for. And I think you're seeing a lot of this, like, well, your doctor doesn't listen to you. So come to our perimenopause platform where everything is sunshine and we will put you on
Yep.
hormones. And that's not the right thing either all the time, right? Like,
Yep.
you need to understand these women, these individuals who are coming to you. And in any corporate model that I've ever worked in, again, been in telehealth since 2016, seen pretty much all of the corporate models that exist. None of them are offering you more than 15 minutes with a patient. And they're actually selling that to doctors like, see 10 patients in an hour, get paid $30 per patient, and that's the model that works for the companies. It doesn't work for the patients. It doesn't work for the doctors. So I don't think that the answer is, demonize your doctor who didn't listen to you, who dismissed you,
Right.
and then jump on our platform and just get what you want, right? Like, this is not Burger
Right.
King. We just have it your way.
I mean, even to the earlier conversations around fertility and management, even in perimenopause, I mean, hormones are one aspect of it, but it's so much more interconnected, right? Our bodies are so complex, our metabolic health and our VO2 max and how our body composition, all these things really matter. You both are women in medicine. You've led illustrious careers. I have a young daughter, I have a wife. I sometimes think, like, would I guide my daughter to pursue a career in medicine? How would you guide a young woman at this phase? Maybe you can describe what you've seen in medicine as a woman at to this point, and then do you think that it's still a career worth going into?
Yeah, I think, as a woman in medicine, I had a great training and a great program. So I felt supported, which is great. And I think primary care also is can be very female predominant. So I didn't see a lot of the difficulties that other women in medicine might have felt. I think in terms of counseling my daughter, I mean, gosh, for all the difficulties and all the struggles, um, medicine is such a privilege. And I think, especially after, 10 years of being folks' physician, you're let into their lives in a way that doesn't apply in other fields. And it's such a unique relationship and a powerful one. And you combine that with like the love of science and, to your point on the complexities of the human body, like every day it's like astounding what we learn and what's new and how it all interplays, and that's fascinating. And you get kind of this like, special view into it as a doc. So I mean, I still love medicine and I love being a doctor and I love that I'm getting to do it in a different way. So I would 100% encourage it. I think you just also need to have your eyes open and realize also that there are other ways to practice medicine. It's not, you have to go out and practice in a clinic and, burn it at both ends like you used to. So there's a
Right.
lot of different avenues. You can be an entrepreneur, you can do different things. So I think allowing yourself as a doc to kind of see outside of that bubble is really important. And that's been the journey I've been on, which has been great. So
Love it. Beautifully said. How about you, Dr. Busse?
I think if you had asked me 10 years ago, I would have been like, no, like, don't touch medicine with a 10-foot pole. More than 10 years ago, right? Because I've been doing telehealth for like almost that time. But even in that time, like I've seen some horrors about how the doctors are treated like cogs in a machine. And if somebody loves people, like to that point that I know I did, and I'm sure all of you did, that when I decided very young I wanted to be a doctor, it was because I loved getting to know people and I really want to know how the inside of them worked. And I wanted to help them figure out how the inside of them worked so that they could live better, whether that was mentally or physically or spiritually. Like I just needed to know how to help people live better. And then you get put in the system and everybody tells you you're basically nothing and they can replace you in a day. And you learn about the corporate structure during medical school. And then you get hired into a hospital because that's the best way to pay off your loans. And all of that stuff can be really scary. And I think a lot of doctors kind of lose sight of what drew them to medicine. And hopefully most of them don't have some kind of horrible health scare like I did that rips them from their comfy seat in medicine and causes them to, change the paradigm that they need to be in. I would rather talk to these young doctors or young people who want to be doctors and let them know earlier, like there are alternatives, like Ash was saying, like you
Right.
can be an
Right.
entrepreneur. You can find that authentic, spark that helped you transition through these really, really hard years of tons of studying and no social life. But it kept driving you there. And there are people who appreciate that. There are patients who want that, who are just like crying out to us to be there for them. And know that you can find your niche in medicine. I tell doctors that every day, those who have transitioned out of the system or are newly coming in. Like, you just have to know, like, what is that thing that lights you up about taking care of patients? Because obviously those patients are out there and they will find you, but you have to be able to use your voice. You have to say, like, these are the kind of people I want to take care of. I want to take care of women. I want to take care of women of a certain age. I want to take care of men. I want to take care of children. Like, what is it that you want to do? And just continue putting yourself out there. And if you're really passionate about like more traditional forms like surgery and stuff like that, like there's entrepreneurial paths for that too. Like there's lots of doctors running private surgical clinics. Like it is not unheard of. And, my vision is that this is going to get more and more common as people are now opening their eyes to the fact that insurance has destroyed their relationship with their doctor and with their own health. So as that, becomes the rally cry of our generation, hopefully there will be more opportunity for doctors to be in relationship with patients again.
Well, beautifully said by both of you. I am inspired by you both every day. I think hearing what I just heard, I feel a lot more confident guiding my own daughter to pursue this kind of career, as long as you sort of chart your own path, right? And I would say that to any physician, certainly our young women physicians, though, that the traditional academic path, the traditional big system ownership is not the only way. All of us have experienced that, but have found ways to sort of break out from that as well. So I so very much appreciate both of you sharing all of this wisdom and knowledge. This is, again, Women's Health Month. We will have another episode where we go deeper on a few other topics here. Any parting words or wisdom guidance for all the women out there who are listening, either patients, clinicians, others, as far as their health optimization and outlook go? Chambers, you want to start, and Dr. Busse can round us out.
I just encourage women to, search for the right doctor, search for the right clinician, make sure you feel like they're listening and that they have your best interest in mind and you feel like you're heard. In terms of health advice, I could talk for a long time, but exercise, keep moving, do all kinds of it, strength training, cardio, HIIT, all of it. I love all kinds of exercise, and I think our body needs a variety. So I encourage every woman to keep working at it.
I would just say, for everyone out there, especially, women, to find someone you can have a relationship with, right? That is the key to healing, is that people who don't feel worthy of their own health are not going to see the opportunities for health. We get so much information put on ourselves, and we think if we don't have, 30 hours a day to be focusing on our health, we're probably not worthy of good health anyway. Until you can find that doctor or other clinician who sees you, who takes the time to understand what will move the lever most for you in your life and your lifestyle. You want to create that relationship with that person. You want to trust them. You want to know that they see you and they hear you, and you want to be able to see and hear them as well, because the relationship has to go both ways. We are not here to tell patients what to do. We are here to guide them on a path that will evolve into the best health that they've ever had in their lives. And that's going to be different for every single person. So unless your doctor's taking that standpoint of like, I'm here to listen first and then help you make decisions based on what you think is best for you, and I'm going to give you guidance that I feel is clinically relevant to your decision-making process, like that's the doctor that you want to find. As far as like staying healthy for the long term, I definitely echo what Ashley said, like stay moving, stay active, do what you love, eat a very balanced diet, protein, lots of fiber, and keep yourself engaged, right? Like I think we talk about health span and lifespan, and we forget about the real connections that make life worth living, right? Our connection with ourselves, with others, and with whatever greater or higher power that you have in your life, that organizing direction that you have. Like that is what makes life meaningful. That is the, as I've talked about with other friends, is like that's the love span, right? Like that keeps us moving forward in life, and it makes health span and lifespan worth having.
As you can all see, we have brought the very best of the best around the table here. Whether you find a team here at Velocity or in your own local communities, you're hearing from all of us that it really is about that relationship more than anything. So for my wife, my daughter, my mother, my aunts, my sisters, both of you, thank you for everything you do every single day, for inspiring me and for inspiring us to build a better way and a better path forward. For all of you listening, thank you again for tuning in to another episode of The Ultimate Asset. We are here to give you the very forward-thinking, cutting-edge education and information on how to protect your most ultimate asset, your brain and your body. So thank you for joining us, and until next time, we'll see you again. All right. Thank you for listening to The Ultimate Asset. Until next time, keep investing in your greatest asset, yourself. This podcast is for informational purposes only and does not constitute professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or before making any changes to your health regimen. Never disregard professional medical advice or delay seeking it because of something you've heard on this podcast. Reliance on any information provided in this podcast is solely at your own discretion.